In this final recording for the respiratory chapter, we're going to talk about some other obstructive disorders that can affect the patient's lungs. Let's start out with the spontaneous pneumothorax. So pneumothorax is the presence of air inside the pleural space of the chest. The one thing to realize is that you have two pleural spaces, one for the left lung, one for the right lung, and these are separated by the mediastinum. Now, if you ever have a chance to do a cadaver dissection, which I hope you do, I think that you'll really see that the mediastinum is not quite this empty space with some stuff in it like you might imagine and you might kind of see in the pictures. It really is pretty solid and does prevent air movement from one side of the chest to the other. So when you have a pneumothorax on one side, such as the right side is pictured here, then the air is going to accumulate on the right side of the chest, and as it gets worse, it's going to start to shift the mediastinum towards the left lung. And that's what's going to end up interfering with the lung on the other side. So spontaneous pneumothoraxes are actually much more common than one might think. It does tend to happen fairly often, and rarely does it become a true emergency. Most of them will self-resolve. But it's when it moves on and becomes a tension pneumothorax that things become more complicated. So patients that are prone towards having spontaneous pneumothorax include those with chronic lung infections. These tend to weaken down the lung walls and cause them to pop and allow air to leak out into the chest. This includes those with emphysema and those with asthma. These patients tend to have weaker walls than others. And those who are particularly young. Another demographic, tall, thin, healthy males. So these tend to have spontaneous pneumothorax more often than their counterparts. So when you have a spontaneous pneumothorax, it's a sudden change. Oftentimes they'll say that they had a sudden onset of pinpoint pain. And the location of that pain is oftentimes the location of the spontaneous pneumothorax. Depending on the extent of the air collection, breath sounds may be a little bit different. A small, simple pneumothorax may have very light dyspnea and have only slightly decreased breath sounds on that side. Patients that are moderate to severe may have from highly decreased to absent breath sounds on the affected side. And then as that collection of air starts to shift the mediastinum towards the side that was otherwise healthy, those sounds will start to diminish, and eventually, once when the patient stops breathing, become completely absent. So other problems that you would see would be consistent with the patient with moderate to severe dyspnea. So pale, diaphoretic, tachycardic, those types of signs will start to show as well. So if you do have a patient that's got an altered mental status, cyanotic, you got those profoundly different breath sounds as we discussed, then you'd be looking at somebody that's not qualifying as a severe pneumothorax or a tension pneumothorax. In terms of other signs that you would see, tracheal deviation is oftentimes brought up in EMT classes. This is a very, very late sign. You would see just about every other sign before tracheal deviation would be present. And just a note on tracheal deviation, it's not something that you would ever see. It's something that you would feel. So you want to take your index finger and your middle finger and put it on either side of the trachea. At this point, you'd be ventilating for the patient. A patient with tracheal deviation would not truly be breathing on their own at this point. When you squeeze the BVM, you might feel the trachea tugging slightly towards one side or the other. Like I said, it's really something that you have to feel for rather than seeing it. And to be quite honest, it's not that helpful of a sign. You should have pieced together everything that's going on from the others. Another note in terms of symptoms. So if you have a tension pneumothorax that's now starting to displace the mediastinum, that interferes with blood return to the heart and the vena cava. The vena cava gets compressed, and you have a decreased blood flow into the heart. Hypotension is another sign of a tension pneumothorax. So systolic, usually below 90, and oftentimes you can have what we call a narrowing pulse pressure, where the systolic is coming down, but the diastolic is staying just about the same. So rather than having a difference of 40 between the systolic and the diastolic, you might only have a difference of 20. And that's what we mean by a narrowing pulse pressure. So these patients are profoundly sick and need immediate intervention to survive. So in terms of field treatment for these patients, So this is going to take a paramedic to really provide any kind of relief in the field. What we would typically do is decompress the chest, placing a needle into the second intercostal space to relieve that tension. So in the future, you'll be going through how to go through and do a chest decompression. That won't be part of the AEMT skill set. So what you can do for now is provide airway support, ventilatory management, and really fast transport of these patients. So what you'll need to do is make it to the hospital in order to get that air removed from the chest. So no dilly-dallying around scene with these ones. Get them going quickly. Otherwise, ventilatory support as best as you can manage. Now let's talk a little bit about pleural effusions. So this is a collection of fluid outside the lungs. Maybe on one side, maybe on both sides. Kind of depends on the cause of it. So it can be from a pleural rub, irritation. It could be from an infectious type process. Or it can also be due to cancer. Also tends to cause pleural effusions. So can occur pretty quickly, can build up gradually. Once again, that kind of depends on the cause. So when you start taking a look at these patients, if they have a history that's consistent with cancer, then you might want to start thinking about this process. So these patients, kind of similar to pulmonary edema, they feel better when they're sitting upright. This allows the fluid to drain down towards the bottom of the cavity, which then allows the lungs to expand a little bit better, so sitting them up is a good idea. And in terms of management for them, you got to bring them to the hospital. So whether you're an AEMT, paramedic, we can evacuate fluid from the chest cavity. So they're going to have to place a chest tube and have a slight vacuum inside the chest cavity to pull that fluid back out. So the best you can do is maintain airway and provide ventilatory support. In terms of a pulmonary embolism, we're looking at a clot that's traveled from somewhere else in the body and lodged itself inside the lungs. This does not block airflow. Lung sounds on these patients will be completely clear, but it does block blood flow. So while the air keeps on moving inside of the lungs, so the blood will not be picking up anything or doing any gas exchange because the blood is not cycling through those capillary beds. Embolisms can be minor, they can be severe. In terms of mortality rate from it, about 10% of them result in death, which means that your chances are actually pretty good to survive. That's 90% survival rate, which is actually not all that terribly bad. 5% of them do tend to be immediately fatal. These types are referred to as saddle emboli. If you have an embolus that sits right inside the saddle that splits between the left and the right lung, that'll block off all blood flow to both lungs. And these patients will go from fine to dead in the space of minutes. So these ones usually comprise this 5% of immediately fatal ones. So in terms of risk factors, anyone that's been sitting still for a long time is a good candidate. If you've ever taken any international flights, you've seen the kind of goofy videos about standing up in the aisles and moving your legs around. That's actually some pretty good advice to take. Other ones particularly involve recent surgery. These patients have had cuts made, so they now have clots at those surgical sites, and if they get into the bloodstream, they can run back up to the lungs and cause a pulmonary embolism. And then another really good case, and this can happen in very young females, is the combination of smoking and hormone-based contraceptives. So the pill, NuvaRing, injections, anything that's a hormone-based contraceptive paired up with smoking will make these individuals very prone towards having clotting factor disorders. And it can both have strokes and pulmonary embolisms at a much higher rate than somebody that does not engage in both of those activities. Some oral contraceptives without smoking will increase your risk factors slightly, but pairing smoking with oral contraceptives will greatly increase your chance. In terms of signs and symptoms, so depending on the amount of lung tissue that is involved, these symptoms may kind of run along a spectrum. If it's a lot of lung tissue, these symptoms will be severe. If it's only a little bit of lung tissue, they'll be relatively minor. So one thing that does tend to go along with all pulmonary embolisms is acute chest pain. the patient will have a sudden onset of pinpoint pain right in the location of the clot. They can usually tell you right where it's at. It'll go from nothing to pretty noticeable. In terms of dyspnea, once again, this is based on the extent of the tissue. It may be minor, it may be severe. A hemoptysis tends to be a very late sign, so that's blood inside your sputum. Not terribly common, very late sign. No. And like I said, various degrees of hypoxia based on the amount of lung tissue involved. One of the big notes, though, is that for the first few hours, lung sounds will remain clear. This is not a blockage of the airways. This is a blockage of blood flow. So lung sounds should remain clear until a few hours into this, where you might start to get some diffusion of the blocked fluid into the tissue around it. At that point, you might start to get crackles in the region of the pulmonary embolism. Otherwise, when we tend to see it, tends to be good clearance. So in terms of how we manage these patients, once again, we're assisting the airway, we're providing high flow O2. We have no ways to remove that clot, so we are not going to be able to correct the actual disease process. If your patient is dead, then initiate CPR just like you would for any other patient. An IV of a crystalloid solution is good to have in place. But once again, this is going to be something that the hospital will be using and not so much. So, severe cases, cardiac arrest, unknown origin. Like I said, if they're dead, give them CPR, shock as indicated. So, general cardiac arrest protocols in process. And you want to go by the appropriate mode of the appropriate facility. If you have profound signs and symptoms, this should be a lights and sirens transport to a facility that can handle these types of pulmonary embolisms. Primary treatment inside the hospital is to give clotbuster medication. So you want to go to a hospital that engages in those types of activity. And then we're going to cover just cystic fibrosis very briefly here. This is a genetic disorder. Patients are typically born with it and tend to die in early adulthood. They tend not to have full life expectancies, and the disease tends to progress throughout their lifetime. This is a disorder in which you tend to have secretions and consolidation of lung tissue that tends to get worse as time goes on. It also affects the digestive system, so they oftentimes have intestinal blockage and other digestive type complaints to pair up with cystic fibrosis. These patients tend to call EMS when they have other complicating factors on top of the cystic fibrosis. So oftentimes we're talking about a CF patient that also has pneumonia and other complications such as that. So what we're looking for is signs of respiratory infection, and about the most we can do for these patients is supportive type care. This is another one that, because it's a genetic disorder, we cannot correct this. It's a complication. You'd expect to hear some rhonchi throughout their lungs, signs of mucus collecting inside the airways. And these patients, like I said, the most we can do is supportive care. If they have some wheezing and some airway irritation, you could try giving some albuterol. Otherwise, there's just not much that we can do. So supportive care, recognize cystic fibrosis. The vast majority of these patients that have it know that they have it, and they're probably diagnosed with it in young childhood.